Okay, so this is case number 8. Very brief, we will show because we almost completed this case. 75-year-old male, again, multiple risk factors. Most important is end-stage renal disease on hemodialysis. He actually was admitted with the non-STEMI to our sister hospital, Mount Sinai Hospital of Queens. So low EF and multiple segment wall motion abnormalities. He had a cath, 3-vessel disease with a high syntax. So he was transferred here to the main campus on the surgical floor. So you can see when the cath was done, that was early part, middle of May. So 3-vessel disease where he had some distal left main, mid LAD, ostial LAD, distal circ. They actually I was there and then said significant disease and he was sent here. So surgeons evaluated him and they felt that he's not a candidate for bypass because of the comorbidities, mainly dialysis. And other thing is that they did find a lot of calcium in his aorta. And I think surgeons usually don't like that. So if you see the angiogram, you can see the mid LAD actually at the level of the first septal.
Well, the big story about this gentleman is also that he's had a intracranial hemorrhage and he's on Keppra, so and with thrombocytopenia, so he's got a lot going on. So hopefully we'll see what's pushing you to do something, and it looks like a tight LAD lesion, isn't that right?
Yeah, no, tight LAD, and then also look at the circumflex. You see that after that ramus and OM, another tight calcific lesion there. Yeah. So they said in the circ they could not pass the IVUS, that was there, but LAD, they got a significant CSA, but we do have ours. So 1.5 bar, and we took care of the circ with 1 stent.
So you didn't use support. It doesn't look like you used ventricular support device here because the EF was normal. Tell me, what was your thinking there?
Bad peripheral vascular disease.
Oh, okay.
But so that point is super important to make too, because I personally really dislike the term protected PCI because it does protect the ventricle, but if your vasculature is bad or you don't get a good, the complication rate is bad, you're not protecting anything, especially if you didn't need it. So this is good judgment, I think, in integrating risk and benefit and then figuring out why. And this may change, though, when you have lower profile devices where the vascular complications might be mitigated.
That's right.
Yeah. So angiographically, if you see that ostial LAD calcific as well as a significant disease, and guess what? IVUS did not show, right? We can show the IVUS of the LAD there. So
can you put the IVUS on the main?
Yeah, we can put the IVUS of the main. So that was 2.0.
This is the mid LAD tightest part.
Yeah, the mid LAD was the tightest part.
Yeah, very tight.
And then we come back to the proximal. Yes, lot of calcium.
Diffuse eccentric cos-5 lesion.
Right at the outside.
And this is
there you go.
Oh, yeah.
Oh, yeah.
Now come to left main.
Yeah. Very eccentric, though. It's interesting. I mean.
Yes.
And it's not really circumferential calcium, So.
And it looks like a nodule right there.
Yeah. But Kiski also shows, you said prox LAD, everything has diffuse disease.
Yes, true.
Yeah. So calcium and diffuse disease, what you typically see in patients with dialysis, right?
Yeah.
Yeah. Okay.
So
there you go.
Yeah, we did a 2.0 bar to the LAD.
It was pinpoint. That was 180 degrees.
I'm back angiogram.
Not as bad as it looked. Not as bad as it looked angiogram.
You did a 2.0 burr on the circ, right?
No, the LAD. No, 1.5 they did on the
1.5?
circ. Yeah, the LAD, because of the size and since the lesion was not significant, we did 2.0. I wanted to do 2.0 to the mid, but you see that I stopped. See how the wire, the lesion is eccentric, and here you can see where the wire is on one wall of the vessel. So as I was going down there, I had more and more resistance, so I just stopped there. We ballooned it, we placed a stent, but that has caused a lot of dissection. Okay, stent was not easy to deliver there either. Look at this. Opened up. So we placed a stent, but then there is a lot of dissection after placing the stent because Kieske did warn us there's a lot of diffuse disease. So ostial circ, proximal circ does not have disease based on the IVUS.
Yep.
So
I know you think the dissections proximal to the mid lesion were kind of wire and rota induced or were retrograde after you ballooning?
Yeah, after balloon.
In that proximal area, is there like, is that a lesion or is there clot forming there? You see in the very, just distal to the maybe in another view you could show us.
Yeah, I see some dissection.
There's definitely some issue there. Yeah.
No, let's go here. Look at this. It's a dissection created by, placing the stent there.
No, but I'm worried about proximal, Anu, proximal there, in the proximal area. You see there's like a cap there on top of the, maybe in a different view.
It's all dissection.
Yeah.
Yeah. So right now, I think our goal should be, if everybody agrees, since the proximal circ is okay, that we will just do provisional stenting left main to that, LAD.
Although I'm a little bit also concerned about that proximal circ. Take a look at that haziness there around that calcium.
That area has been, I was showed that to them. It is all calcium with this guy.
This is the proximal circ. A lot of calcium, but area is fine.
Yeah, go back. This is the IVUS of the circumflex.
Yes, and this is the tightest ostial circ, but area is 6. Eccentric calcium, but area is like fine.
5. So remember the first case we did, a similar circumflex case where we had left main and circumflex. At that time, we were like 4.2 at that time, the first case. Yeah, that time I was not comfortable leaving that. I said, we have to take care of it. Here I am okay to leave it.
I just think about the fact that this guy is not going to be able to take anticoagulants or antithrombotic regimens very well. So because of all of the thrombocytopenia, prior intracranial hemorrhage, etc. So.
Yeah, so no point doing the double stenting. Let's place once, I think, provisional stent and see how he does. Right? Mm-hmm. Do we have this guy's been on Plavix, right? You have a PRU?
He's on aspirin and Plavix from what I'm seeing.
It's good, right?
You want to see it in the cranial view, maybe, also?
And I will. I just want to see.
Ready? I don't think you're on top of the other stent yet because of that bend.
No, you're good.
Okay.
Yeah, that's a nice overlap there. Only question is I don't want to double jail the DAG.
What's the diameter of the stent, Anu?
4.0.
4.0? Okay.
Mm-hmm. What do you think? See, we'll double jail the DAG. No other option, right?
I don't like that distal edge either.
We will, distal edge of the LAD. You mean
the distal edge of the stent in the LAD.
There's wicked tortuosity in the LAD too.
Yeah, calcium and tortuosity, not a good combination.
Okay, now you want a cranial view, ready?
Yeah, I tend not to like to put so much stent in a dialysis patient also.
I think you're overlapped there, huh?
Yeah, I'm going to pull back a little bit so that
way you don't double jail.
is a little bit. Yeah, otherwise we'll lose another branch. Okay,
that's good.
Some die.
That looks better.
Yeah, okay, go up.
That's nice.
And then I think what we'll do is we'll just balloon the distal edge of that stent. I don't want to put more stent there.
Yeah.
And do a good balloon. Yeah, good.
Anu, are you using any agent for that sort of distal disease that in the past we tried to avoid stenting and we just massaged previously and that kind of thing, or is the cost too prohibitive?
I think cost is prohibitive at this time. But we have done in young patients, we have done a couple of cases. I think we have done 2 cases, Monday and Tuesday, and ISRs.
Yeah, no, that's the shame of it because.
Not a 2-layer, yes, not 2-layer.
I mean, the
single-layer
cost is
ISR.
crazy, Ajay. I mean,
Yes.
it's literally, over
I
$5,000
want IVUS
for a
and then we do
balloon.
it, right?
But I think that, honestly, having it around,
Okay,
like those
good.
types of cases,
Oh, no, for
mid to
sure,
distal LED
sure,
and
for
that kind of
sure.
thing would be great, but it's a challenge.
Using it a lot at Columbia?
No, we have to, in order to do it, you have to call another doctor into the room. We're trying to use it for cases where, look, it's ISR that's refractory and that kind of thing. We have an active brachy program just like Sinai does. So there are cases, longer lesions where brachytherapy still makes sense. I know Ron, I think they gave a talk on this earlier, but yeah, the cost thing, hopefully with reimbursement and pass-throughs and all that, it'll be better. And interestingly, when that happens, that would apply to whatever you use it for, even if it's not ISR, even if it's off-label. But for now, it's slow. It's going to be difficult.
So we're going to pot the left vein now.
Yep.
And then IVUS. I won't take a angiogram, but we will IVUS. 14, 16.
The one thing you want to be careful with is that
Done.
that outflow lesion is your outflow for like 60 millimeters of stent. So you just want to make sure that's got a good lumen.
We go here, but don't get crazy. Yeah, let's 6, 8, 10.
Just for the sake of argument, would anybody have not done ROTA and just done either a NC balloon or IVL or anything else?
No, it's a good thought, but I don't know about IVL here. I mean, I think,
I tell you, with the renal
but that could have
patient-
gone.
With
Yeah.
the renal patient, I'd love to keep it just short and simple and maybe use IVL and just spot stent and see how they do.
Because the thing is, most of the expansion is going to be on the non-calcified wall. And so honestly, we don't know if regular balloon or NC balloon and stenting would give you just as good as MSA as anything else that you did. So.
Yeah.
Okay, we're going to IVUS and let's see our final result. All these surgical turn downs, we also struggle a lot always. Calcium tortuosity
Yep.
on a dialysis patient.
I mean, this is our second or third dialysis patient today for these complex cases. Second, for sure. We had another dialysis
Yeah,
patient.
the first one was dialysis and this one.
Yeah.
Okay, you see the distal edge?
Yeah, still interesting.
Still
you get
interesting?
distal
Okay,
to
good.
going?
Can you go distal
Don't
to
even
that
go.
edge? Yeah, please. Because
It's
that's
just
what
a
I was
I
just
start to
worried.
work.
It looks like it's just eccentric calcium.
Yeah.
Yeah. Flush.
Come on, guys.
No, we have to repeat it. We missed the distal edge.
Yeah.
Okay, I'm going back. Okay.
Yep.
Okay.
So supposedly,
No flush?
there will be a new catheter for this system,
Oh.
in the next 6
okay,
months or
start to
so.
work. Coming. Yeah, I saw that distal edge. Looks good. Very expanded.
Good,
Nice.
right?
Full cover the lesion. Now
So
coming
it's
to the
just
left vein.
stent is on the plaque,
Yeah. Okay.
right?
Yeah.
And
Oh,
then
yeah.
we see the diagram. I mean,
All the
circumflex is
dissection is
okay.
covered.
Circumflex is okay.
Yeah. So
How
here
is
is
the
the
left vein
distal edge.
expansion?
Distal edge looks like okay. No major
Yeah.
dissection.
Yeah, see, that's nice. That's why the imaging takes all the guesswork out of that. The distal edge could have been a dissection, could have been a small
Yeah.
lumen, but it was just some eccentric calcium.
It doesn't need to be
Yes.
treated.
Yep.
Exactly.
So I
And they're
think
all covered all the way to the left
And it's
vein.
the same thing in that proximal circ too, that to me looks not so good, but
But it's all calcium.
it's calcium.
Who's that?
Yes.
Okay.
Prox LED is, we need to post.
Post dilate.
Yeah, I think we are good. Yeah, we'll post dilate the Prox LED, but I think otherwise we
I
are
think
good.
that looks great.
Another
Thank
case?
you, Dr. Kinney. I think we're going to go to
Good
keep the
job.
time going. Beautiful. Thank you.
Both cases, great.
Bravo.